my good fortune to actually meet Dr. Jennifer Tseng through the North American Taiwanese Medical Association, where we had a faculty committee that was just getting started, and because I know that she has been coming to Taiwan, and I invited her to see if she's interested in participating. And within a few minutes, she replied back, and we were very lucky to have her. Dr. Tseng is an accomplished upper GI surgeon and a surgical oncologist dedicated to advancing surgical outcomes, healthcare equity, and healthcare quality. She earned undergraduate degree from Stanford University, her MD from the University of California at San Francisco, UCSF, and an MPH from the Harvard T.H. Chan School of Public Health. Dr. Tseng completed her surgical residency at the Massachusetts General Hospital, followed by specialty training on surgical oncology at MD Anderson Cancer Center. She began as a faculty member at UMass in 2005, where she founded the Surgical Outcomes Analysis and Research SOAR initiative. She moved to Beth Israel Deaconess Hospital in 2011 as Chief of Surgical Oncology, where she rose to the ranks of professor at Harvard Medical School. From 2017 to 2024, Dr. Tseng was chair of surgery at Boston University Medical Center and surgeon-in-chief at the Boston Medical Center. At BU, Dr. Tseng spearheaded education, increased departmental prominence, promoted faculty, and improved clinical quality, research, and funding. She is past president of the Society for Surgery of the Elementary Tract and is a founder and past president of the Society of Asian Academic Surgeons. Dr. Tseng is a member of the American Board of Surgery Council, the director of the Complex General Surgical Oncology Board, and the deputy editor of JAMA Surgery. Currently, she is focused on working in health equity and advocacy, including improving access to care, service, and medical and philanthropic organizations. She's doing some consulting as well as writing projects. Please give a warm welcome to Dr. Tseng.
A special home for me, so I really appreciate this. So I have tremendous gratitude to so many, obviously to the Koop Foundation, Tseng Cancer Center, to the inimitable Dr. Wong, who is such a founding spirit. I have known of him for a long time, but this is my first time actually getting to meet him, and I'm so grateful to be inspired as so many have here in this room and in the world, on multiple continents, and so such a pleasure. And then of course to Jason, to Dr. Wong, who is now somehow already a dear friend and colleague and somebody that I respect very, very much. And indefatigable Patrick Wu and the whole staff, and just incredible here. It's really a family feeling, and I know those connections will continue forever. But I did want to do something a little different here. I would say after I heard from Jason and about this conference and the theme, I really wanted to concentrate my remarks on the conference. So when you get to be my age, you actually have a bunch of canned talks that you give everywhere. But I actually decided to throw out all of those talks that I have that involve surgery and lots of videos with fancy operations and robotics and everything else, and data around pancreatic cancer and screening, and actually just try to concentrate on the topic at hand, which is the future of medicine, the future of medical education, especially as pertains to Taiwan and countries like the U.S. that may have insights or connections to Taiwan. So this is a little bit more experiential, and I hope you bear with me, and I would like it to be interactive if you have questions. So I'll signpost a little bit. I just wanted to start with some beginnings and talk about the promise and the peril of our age. You've heard so much from the other illustrious speakers in the panels, a little bit of what I've learned, poor Patrick. I keep sending updated versions of the slides as I've been inspired by some of the things that have gone on during this conference already. And then at the end, I want to talk about back to basics. I think getting back to humanity in medicine and medical education is about why we all chose to go into medicine in the first place. Why did we do that? And I think that is our key to inspiring young people to continue to go into this profession, which is so necessary and important. And I would argue that in surgery and in every field, we need to take all this glut of new information and organize it in some way, not memorize it, but organize it while holding to our true center. As Harvey said yesterday, Dr. Pfeiffer said, you know, put the patient at the center. If you put the patient at the center, everything else will follow. The humanity, our human connection, as Dr. Wong so eloquently said in our introduction yesterday. So this is my son. In 2006, I showed up at my first job pregnant with him, and then had him that year, and then this is after we spearheaded a walk for cancer at my first institution, the UMass now Chan Medical School in Worcester, Massachusetts, and we just come back from this walk, and he clearly is not making any kind of political decision at the age of 0, but is thinking very carefully and weighing the options for these two balls, probably which one of them to throw at his mother, who's like sitting there trying to restrain him, but this is our beginning, so why we do what we do. So again, this is my father, my late father, Tseng, was classmates actually with Dr. Wong at Tsinghua. Enlarge it. Well, so this is not my father. This is my husband and my kids. But he used to say this thing to me when I was little, which I didn't really understand. But it's 计划没有变的话快. So what that means, and so he was saying to me all the time, maybe when I was like trying to steadily, I'm a planner, trying to plan really hard, and it means, I knew it meant something, like, you know, these plans that you're making, you know, they're not gonna work, like things are gonna change, and there's another whole long saying he would say after this, but this is the part that I remember. And so I think so it means that that you make all these plans, and then change happens, stuff happens. And then the plans that you've made are not right anymore. So Dr. Feinberg yesterday quoted Wayne Gretzky about not in hockey, not skating to where the puck goes, and it was already alluded to again today, but you're skating to where you think it's going to be. So all these things are predicting about skating or operating or designing a healthcare system, not where we think today is, but it's going to be robust and last and sustainable for the next centuries and into the next. So this is my finally being able to bring my teenagers, that's the boy, the tall person, and all the way on the right is my son, now kind of grown up, 19 years old, and then my daughter, 17, and my husband, who is reluctantly dragged here all the way across the country, but across the world, but in Kaohsiung. And so that was December 29th, 2024, this year, after I gave some talks at Taida, and then I gave some talks at Tseng University as my excuse to drag my family out here. But things change, and yet some of our core values remain the same. And it started me thinking on this whole journey as to our roots. And I dug up this picture, which is taken in the same place. So that's me with a circle around my face. I was brought here, I've been here many times, but my most formative experience, so why I consider this my other home, was my mother was a professor at Furen Dashi, a visiting professor, when she was the head of two different educational systems in the Bay Area and then in California, and then Hawaii. But she did a sabbatical from San Jose State to Taiwan and Furen Dashi, which is the Catholic University of Taiwanese now, in the outskirts of Taipei. So she plopped me and my younger brother in boarding school at Guangzhou, which is Catholic Taiwanese boarding school, music school. And so I was propped here as an American 9th grader teenager with Chinese that was much inferior to Janie's over there in this school. Like I had to learn ancient Chinese and about the geometry in Chinese. I got a B+ in English, I don't even know because I didn't like my pronunciation. So I did better in math than I did in English, which was kind of surprising. I didn't do it well at all vacation that we took in the middle of the year, and I was able to go with my classmates. And these remain some of the most joyous times of my life, and I think these are formative experiences, but that tells to me a lot about why I went into medicine, actually, and what connects us. So I will just put this in to tell us that change comes sooner, and that yet some things remain. So we're here to talk about medicine. So I think we know our pace is accelerating. Dr. Harvey, Dr. Feinberg, is the head of the Betty and Gordon Moore Foundation, which is an incredibly important foundation devoted to access and also to the Bay Area. But of course, Gordon Moore's famous for many things, being a co-founder of Intel, but also for Moore's Law, in which he was a response in Electronics magazine to an editorial. But he stated, which is well known here, but the complexity of complex circuits, he's talking about silicon chips, will double yearly and the cost will go down. And that has not only been used very effectively over decades to actually predict what it was meant to predict, but also used as an aphorism to talk about the rate of change in our information glut in our particular society. It's proved incredibly prescient, but I think of it as life gets more and more and more and more complex. The cost doesn't necessarily go down, although it does for electronic components, but it's certainly not for healthcare, but it is an exponential expansion of information. And that's certainly true of medical information. And there's so many articles. This one was actually fairly useful in an AMA, a journal called Medical Teacher, but it was talked about exploiting the power of information in medical education. There's so many ways in which the information is growing and is useful, but it's actually almost overwhelming. And finally, at least in English, we have heard so much in the last 5 years about we are living in unprecedented times. I am so sick of that phrase, unprecedented times, that I think we really have precedent for using this phrase too much. But we have global pandemics, we have turmoil in politics here and abroad. And by here I mean Taiwan, but also abroad meaning the United States and Europe and everywhere else. We have that is engendering a turmoil in science and higher education. And these are crazy times that we live in. How can we build interest in medicine and medical education? So these are just an illustration of the age of information. I guess, given this, I should have disclosed I'm a deputy editor for JAMA Surgery and receive an honoraria, but this was just the most viewed articles in JAMA, one journal, albeit a highly read one, in 2024. But somehow, just to be abreast of the top of what we're supposed to know from medicine, we need to know about GLP-1 inhibitors, we need to know about cannabis, we need to know about cardiac stenting, we need to know about everything under the sun, bilateral mastectomy for breast cancer. We need to know everything to be even a superficial expert in medicine. So for surgery, again, these are my own sort of robotic type pictures, but this is from just people that I hired or mentored at my former institution, Boston Medical Center. This is Krista Jesu on the left, performing surgery on an XI robot, so it was then the state-of-the-art intuitive robot that cost at the time, 5 years ago, $2 million for a SafeNet hospital. I have faculty that write me nasty letters that say they wanted 3 more robots because they need a robot to do everything because it's better for the doctor. They think it's better for patients. Well, it costs twice as much money. The outcomes are no better, but at least in the United States, this is becoming the standard of care. And surgeons are no longer able or feel like they're unable to do if you're an oncologist, do a fibroid resection just using laparoscopy or just being open. They need this $2 million robot. The insurance company pays you no more money to do the operation robotically, but it costs the hospital twice as much to do. And at least right now, it takes a surgeon twice as long to do it. So do the math right there. If you're a SafeNet hospital, or even if you're not a SafeNet hospital. And to the right is Dr. Tevye Sachs, the chief of surgical oncology, who was my mentee, my resident, and then my hire, and my chief of surgical oncology, now doing intraoperative ultrasound. So you could argue that he's doing intraoperative ultrasound to see. These are tools that we pay lots of money for, that we haven't, but they're not driving, they're potentially improving healthcare, potentially, especially with the ultrasound, but they're certainly not making the costs go down of healthcare, and I'm not sure they're actually improving the outcomes as of yet. But there's a whole bunch of technologies they need to master that are not technologies that I mastered when I trained. I was still operating. How do we have that continuing medical education? And then we have the economic forces I just put here. Until the last interesting February, all these technology companies are steadily becoming a larger presence on the stock market and in the financial arenas that drive much of what we do and the companies do. Of course, NVIDIA is not a technology company. It is for AI, just like I put it there. And then this was, again, I'm not going to show you the video for this, but this is a minimally invasive transdivisional ampullary resection. I do Whipples. This is something we could do instead of a Whipple operation for an ampullary tumor. We did the first one in New England with the robot. It took us about 8 hours. It would have taken me 2 hours open to do this particular case. It wouldn't have been a Whipple. It was a transdivisional resection of a tumor, which I could certainly do open. I love to do open. And it took us about 8 hours. It was a beautiful case, so we have the video available and up to date. It's great. Everybody wants to do it this way, but how do we justify doing it this particular way if it costs more and the patient outcome is no different? So with that is coming an age of disconnection. So Dr. Brooke alluded to some of this, but our medical trainees report that they had they call it work-life balance concerns. We both agree we don't like the term work-life balance. I firmly believe that work is part of life. We went into medicine because we love medicine. Work is an incredibly important part of a large part of our lives, and that is important. And when we do it right, our loved ones know that. Even our little ones know that it is an important part of life. But I consider it home and work, so home and work balance. You could call it something else. Dr. Brooke calls it work-life integration. But medical trainees, nonetheless, no matter what you call it, they strongly choose things, not just based on what they want to do or what they think is mission or calling, but what they think is sustainable with the kind of life that they want. Are people less likely to choose medicine? I heard that is not true in Taiwan, but in the United States, it really is a very real issue. And if you're talking about science, about research, right now I just had emails from my dear friend and colleague at UMass I collaborated with, Candy Lee and Victor Ambrose, that just won the Nobel. He won a Nobel Prize. She did the work. He's the first one to say it. But Candy just emailed us on Facebook and said they can't hire 6 new faculty members. And the person who just won the Nobel Prize is not able to hire graduate students at UMass this year because of the current budget cuts of the government. And so people are certainly going to be less likely to choose scientific research. And I think they're going to be much less likely to choose medicine as a career when they could do something, as clinical medicine when they could do something else. And then for physicians in practice, at least in the United States, are reporting burnout. They hate the epic, they hate documentation. AI is going to solve all this, of course, we hope. But insurance, prior auths, denials, all the paperwork, compensation, worrying about compensation, and a feeling of decreased respect and satisfaction. So I don't have any, in 30 minutes, I don't have any big prescriptions, but I would just suggest a mental exercise that we can do or suggest to our trainees or even to our partners to at least think about it. So surgeons are quite simple. We are able, more than any professional, to sometimes shut out the noise because you have to. When you have a patient on the table in front of you and their life is in your hands, you have to be able to say, you know what? I may have had a fight with my spouse yesterday. I may have to, there's a lot of stuff going on in the hospital and people are at me, but if I'm in the OR and the patient's life is in my hands, on some level we have the privilege if they will say, stop, turn the radio off, right now we're going to concentrate. I know that's a true privilege and a gift. It's a saying that, I can't be here right now, I need to concentrate. I think we all need to take that surgical skill, and I bet pilots do that, but I think we need to take that surgical skill and apply it in a limited fashion to be mindful of what we do in medicine and in life. And in that, I put the cut as to cure because the stereotype is that surgeons are cold, unfeeling, mechanical, robotic, and inhumane. And it's a cut is to cure, hot lights, cold steel, you know. But I don't think that's true. So I think to cure is to cut the noise. But out of that chaos, we need to do some containment, have compassion for our patients, most of all, but ourselves and our colleagues, and then come to our center, our core values, and then emerge into the chaos with some degree of inner calm. So I will give an example that I use when I talk to my patients, because I think that my patients, I learn everything from my patients or my students, one or the other. So in many years, 25 years of dealing with patients that with the worst kinds of cancers, I have some sense of what works for them. And this is what I tell them, and I think this is also what I tell trainees and doctors that are looking for some way to calm themselves. So when I was going through residency or training, and before that, I would think about this. But there was a movie that came up called Gremlins, and I hate all these movies because they scare me, but it was about these little guys that pop out, like green monsters in a box. It doesn't matter what it is, but imagine some terrible little monster that you can contain. And my patients, when you tell a patient they have cancer, or they think they might have cancer, or they read on a radiology report that comes before the doctor has time to tell them about what happens, they're sure they have cancer, they think the torn meniscus is the cancer, they think all of a sudden it's terrible. I tell them to picture that thing as a little green monster. So if a person, and this is not some psychology, this is my thoughts, but if there's a patient's view of themselves, or a doctor's view of herself, and then you have values, and there's some intersection of the two. When something unexpected blooms, like a cancer, that is huge. That seems to take over everything. That monster takes over everything. And in fact can engulf in that patient or that person or that doctor's view everything about them. Their values, their self, what's important, it upends everything. All they can think about is this cancer or this chaos or this possible threat. So our job is to help them as clinicians or to help doctors, if we're trying to help trainees and doctors, but I'll go back to the patient analogy, to be able to contain that green monster, to contain it, and be able to say, you know what, yes, it is an ugly little green monster, but I'm going to figure out, I'm going to identify it, I'm going to circumscribe it, and then I'm going to contain it. And to try to push that cancer to where it's going to be, or the chaos, the problem, to push it, to identify, to circumscribe it, and push it to where it needs to be in that person's life or in their psyche. And so the point is that with a cancer, going back to that analogy, they want to figure it out, come up with a plan, have a team come up with a plan, and be able to put that green monster in a box. This is safe in my hotel room. In a box, on a shelf, in the top shelf, and then when necessary, take it out, take the box down, put the combination, take the box down, open it up, and feed it as necessary. So you need to be able to go to Keynote, you need to be able to go to your appointments, you need to get your 6-month scan, you need to do those things. But the rest of the time, as best you can, there's going to be some banging on the box, but the rest of the time, you're going to be able to go about your life and maintain yourself and your values, because you are not that cancer, you are not that chaos, you are not that stress, you are not that pressure, you are not that problem. You have yourself and your values, and the more you can separate and contain, the healthier it is for you as a patient, or for them as a physician, cutting the noise and containing it. So what's at anyone's center? Now these are patient anecdotes, but what is, I'm a surgeon again, so we're anecdotal and concrete. So this is a patient of mine. And so he came to my clinic at the Beth Israel Deaconess Hospital, but he came and I was told by my wonderful nurse, this patient's kind of a jerk. He's kind of rude, and she's like, is he an engineer? I'm like, hey, my dad's an engineer, my stepdad's an engineer, my brother's an engineer. She's like, well, he's just very locked down. Maybe he's like, he has Asperger's. And I said, we're cruel in medicine. We come up with these phrases about people. And this is a guy who's told he has a tumor on his pancreas. And so I'm lucky. I only generally see 8 patients, and sometimes I'll see whoever is coming, but I sometimes have seen 20 and 30, but mostly I have about 8 patients in the clinic, because I usually have 2 pre-op patients that take like an hour and a half if we have a hiccup, and I see post-ops and things like that squeezed in. But so he was there, and I will say that I didn't really feel him for that hour conversation. He was very But we got him through. He asked me a zillion questions, like an engineer, he's very smart. He asked me a zillion questions, and he had a tumor on his pancreas with high-grade, at least high-grade dysplasia, IPMN, like a DCIS of the pancreas. And we scheduled him for an operation. Then the first, getting him all the way to pre-op, it was the same kind of affect of him. But then I will play this. This is working. No, sorry. Sorry. I'm going the wrong way. How do I go back this? You played this, Patrick, right?
They'll
You're gonna play. Okay, so I'll play a little bit and then cut off when I show. I don't want to hear myself.
Charlie Bulmetis is living his dream.
This is courtesy of the Beth Israel, so you have to consent to all this because he made this.
I start waking up around 6, and then
Totally different guy than what I
and they start by.
After 20 years of running a pest control business in Worcester, he now spends his days on a picturesque Vermont countryside on the cozy farm he built with his wife Cindy.
I said, okay, once we get retired, I want to have some farm animals. And she looked at me and said, why? I said, because I don't want to just retire and sit and stare at the mountains all day. I want to do stuff.
That stuff includes tending to 8 sheep, 26 chickens, 2 ducks, and oh yeah, 30,000 bees.
Good dog, so you can sit there. A lot of times I'll just sit and watch them. You know, I'll sit in front, watch them go back and forth, and the fruits of the labor. Honey's nice. It's good.
But Charlie didn't know if he would make it to retirement. Bouts of severe stomach pain led to scans. A small spot on his pancreas was growing larger.
In general, these types of tumors will progress, and we know that.
Please stop the video.
Dr. Jen?
Anyway, so the reason I bring this up is this was going on in his head. He had saved up all his money from his pest control business to buy this little plot of land in Vermont that he was planning to retire to with his wife. And he had all these plans, and this was completely derailing this. And he was a very organized guy, but it was completely derailing his whole life plan. And this green monster had come barreling into his life, and every single one of us at VI Deaconess who was trying to approach him in our way, we were just derailing his view of his life. And so I showed that story because the funny thing about this is that the way I found this out was 6 months later in the post-operative visit. Once he was all done, he's done with his adjuvant, he's done with all this stuff, and he said, you know, I'm moving to Vermont. I need to change my registration. I'm moving to Vermont. And then he's like, my sheep is pregnant. And I said, what? What do you mean your sheep is pregnant? He's like, I have a sheep, and she's pregnant. And if the baby is a girl, I'm going to name it Jenny. And if the baby is a boy, I'm going to name it JT. And so that's Jenny. He's holding Jenny. And I was a little bit worried because I didn't know if he was going to eat the sheep or what was going to happen to the sheep. But I was pleased he didn't name it. It wasn't a cow and it wasn't a pig. So he named it Jenny. And Jenny is like, I think Jenny's probably passed away now. But he would send me pictures of Jenny's kids and then her grandkids. And then I guess it's not kids, but like whatever, lambs, and then grand lambs, and then great lambs. There's like a whole flock of sheep that are my descendants, really. So I'm an aunt to this sheep. But I bring this up because this guy was dealing with his great monster in his own way, and that was to be as rigid and as as rigid and as controlled as possible, to not completely have information overload for what was going on for him. So that was and he's doing wonderfully well with both his sheep and his real grandchildren. And then another example, again to be anecdotal, is at my most recent hospital is Boston Medical Center, which is a completely safety net hospital, completely different patient population than the Israel Deacons, except for the ones that followed me there, which is quite amusing. But we have patients from very generally underprivileged backgrounds that are the most wonderful patients in the world. But when they get a diagnosis, it's absolutely devastating. These are people that take 3 different buses to get to the hospital. They cannot afford to miss 1 day of work when they do. They may be undocumented, and they don't work, they don't get fed. They may not have health insurance. They are immigrants and amazing, to stereotype, amazing patients, but they can't even afford to get food for their kids, let alone to pay for a wig when they have chemotherapy or whatnot. But so we have a fundraiser, a fashion show where we have some professional models and the designers donate their services, but they even have comic relief because they have some of the doctors act as models. But the star of the show for the models are the patients, and it is incredible. And we center them. So you see these people, men and women, that have been so brutalized by their cancers, looking amazing. Some of them are in little chemotherapy. They'll push their chemo pole while they're IV, while walking the catwalk, but then their families are there, and we raise lots of money from donors to try to make them feel good and do good for the hospital and raise money for wigs and things like that. But these are just examples of how we center the patients, and I do think they're examples of humanity in medicine and why. And with stories like this, I think we can tell our trainees that there is a reason to go into medicine, and that there is a reason to cut through all this noise, that there's a reason to figure out ways with AI or whatnot to try to decrease the noise and increase the pleasure that we get in medicine. So back to basics, what's my center? And I urge you all to find your center and to have your trainees find their center. These are my parents. Maybe Dr. Wong can recognize them more here, but this is Tseng. It's my dad, and my mom's on your knee. And that is me as a baby, the same age as my son was in that picture at the University of California, Berkeley, when they were getting their PhDs conferred on them. And I will say, just to acknowledge that my dear father passed away in 2017, and then years later, my lovely mom was introduced to, or somebody came calling, who was also a widow after 50 years. These are just more Taiwan connections. So my second father, I'm so lucky, is Tseng, or Kong Xin, who and then that's his brother, who's maybe recognizable to you, who is Kong Xin, who is a cancer biology PhD researcher at Taipei Memorial Hospital. And so he is a very famous cancer researcher, as a professor at UC Berkeley, but has decided to basically, like Dr. Wong, spend full time in Hong Kong, in Taiwan, giving back to Taiwan, and he loves it here. TMU is his home. I think he's still a full professor at Davis, but he's here doing cancer research and again continuously funded and doing research here. But there are two brothers, Gadi, and their stories. But this is the story of the Taiwan-U.S. connections. These are all people that came here and came from here and then went to the United States, built lives and built wonderful careers in the United States, and then come back frequently to Taiwan. My stepfather has founded many companies, but most recently 3 companies in Taiwan and 1 in mainland China that are on AI, they're AI optical cables. But it's all, and this is stuff that gives to the United States, it gives to Taiwan, it gives to the AI industry, Silicon Valley, and there's just so much potential between Taiwan and the United States and all the connections to and fro, and I think this symposium really illustrates that. So again, back to my basics and my roots. This is, again, in medicine. So my stepfather, Zhang Su, was a surgeon, and he came to Taiwan first, worked at the Tri-Surface Military Hospital in Taiwan, and then he went to the United States to do his training for cardiac surgery at City of Hope, and then came back and went to Taida. So he was a professor at both the Tri-Military Hospital and then Taida for years, and I, to this day, meet many students of his that are now professors and retired now, that were trained by him. But maybe more importantly was my grandmother, who was Guan Li, who is an OBGYN and a primary care physician, who, while he was at the hospitals, she was taking care of 4 children, but then practiced full-time running a clinic, a primary care clinic in their house. And then they had an ambulatory surgery center on the 2nd floor of their house, and she would assist my grandfather in doing nighttime operations here in Taipei, and their little, at night. And then my mother, Diane, who was this little girl here, so all the way over the front of that one, and over here on the right, on this one, and over here, she would, as a little girl, would deliver prescriptions and medical supplies the streets of Taipei by herself, very safely, all over. So it was a family affair. And so medicine was something that they did because it was a service. But my grandmother, there's still people that stop me to this day and said my grandmother saved their life because she gave them penicillin when they had an infection, or she diagnosed appendicitis and they took out the appendix with, you know, in the nighttime in their ambulatory service center here in Taipei. So I think medicine is truly a calling. It's a privilege. My grandparents could have done anything when they chose to do medicine, even when they flew in mainland China, coming here, eventually went to Ethiopia, and then going to the United States to follow there. So medicine is a true calling, I think, and the more we can get back to the fact that it's a calling and a privilege and a joy. And so this is just more about, I think that surgery and medicine are all about remembering the humanity. It's all about putting the patient first and choosing to do medicine because it is the thing that calls you, and not because it's the thing that pays the best and the thing that you work less and get more. It is truly something that we do because it's a joy, and all of these tools should be used for good, whether it's AI or all the other advances that we have in robotics, but to try to decrease cost and be able to have doctors working at the top of their license as to what truly makes gives them joy and at least purpose. So again, for patients and for all of us, we need a team. So Dr. Brooke alluded yesterday to her telling her trainees that, no, I know the consultant came, I know the surgeon came and said the patient didn't need surgery, but you're the doctor of the patient. I tell my patients this as a surgeon. To get back to the humanity, I'm not just the boss because I'm the surgeon. The patient, the person whose name is on the medical record is the attending of record. So I tell my patients, listen, we're a team. Even if we're not seeing everybody at once, you are a VIP on a bus. You're Taylor Swift, and we're driving across the country. You're a Taiwan pop star, and you're driving across Taiwan to give a concert. You need a whole team of drivers for different territory. When you're a regular patient, your primary care doctor or your hospitalist is driving. They're the doctor. Then you have all these other advisors on the bus that are giving advice to the primary care doctor or the driver now, and they will filter you the information that you need to hear in a way that you can understand it, and they'll answer all your questions. There may be a point, like if you need surgery, that I will become the driver. Your primary care doctor, your GI doctor will then take a seat in the front of the bus, still available, still on the team, but I will drive with input from everybody else. And I will communicate with you everything everybody else says. But you don't have to move. You stay in your VIP seat, and you get informed, and you ask questions, but we are all here for you. We are your team. You are the VIP. And then we will switch. And when we get to survivorship mode, somebody else is going to take over. When we get to adjuvant therapy, somebody else will take over, but I will still be there on your bus. And so it's not a surgical slide talk without having some gory pictures from surgery, and I will not go with the various steps in here, but I will just say this is, of all the advances we have in surgery, I would harass us on the panel, there are amazing technical breakthroughs, there are amazing technological breakthroughs, and there's amazing breakthroughs like AI. This is one that we did relatively, not early on, but early in my career, but we really showed at MD Anderson and beyond, where I went at UMass, and that you could do vascular resection with liporesection with pancreatectomy and prolong people's survival. People that were considered unresectable before were then unresectable. People that we would leave tumor behind, we could not leave tumor behind because we would do chemo first or radiation first, and then you could be able to resect and reconstruct these essential arteries. To orient you, this is the portal vein going up and down, giving 3/4 of the blood supply to the liver. The hepatic artery coming across gives the other part of the blood supply, but the part that's more vascularized. You need both to be able to have the liver perfused. So on the left of your screen, you can see there's a saphenous vein patch with the arrow on the portal vein being rerouted. The one on the far right, you can see a total interposition graph where the internal jugular vein from the neck has been placed there to reroute 70% of the blood supply for all the blood from the intestines, but 70% of the blood supply to the liver. And then in the middle is the most complex of the operations, which is the big vein patch on this portal vein, but then the hepatic artery coming across was also involved with tumor, and has been replaced by a saphenous vein. So that was a patient who was a relatively young 45-year-old patient with pancreatic adenocarcinoma who came to a very famous Boston hospital and had an operation, which was what we call a peek and treat. He came in, was promised he was going to be cured by the surgeon, he was a wonderful surgeon, was opened up, they found there was tumor involvement of the hepatic artery and of the portal vein. He was closed with a big incision, said, go home, 6 months of chemo if you want, and you probably have 6 months to live. Get your affairs in order. He was told that because he was smart and he was educated and he was privileged. He did a bunch of research on his own. He came down to MD Anderson where I was a fellow and got some advice by my mentor, Doug Evans. And then he came back to Massachusetts and had chemo somewhere else and radiation somewhere else, and then came back to MD Anderson and had this tour de force operation. So there's so much to assimilate. So doctors worry they don't know enough and they don't know enough techniques. Patients feel like they don't know enough and the doctors don't know enough. They don't trust Anthony Fauci. They don't trust us. This is just in my newspaper this week that people don't, what do we all get wrong from COVID-19? And so we are, young doctors are starting to feel, and old doctors are starting to feel that patients don't trust us. They don't trust science. What do we do? Well, again, getting rid of the chaos, or at least trying to contain it, getting back to basics, I would say that no matter what, we can talk about politics, we can talk about science, disinformation, all we have is what we have. One of my favorite quotes is from The Lord of the Rings. And I urge you to read it, or I urge you to at least, you could watch the movie, which is absolutely lovely, and they do have this quote in it. But so Frodo Baggins, the Hobbit, the hero, the little hero, says, he's talking about the rise of evil in the world, but he said, I wish it had not happened in my time. And then Gandalf, the wizard, says, so do I, and so do all who live in such times. But that is not for us to decide. Which is kind of freeing, right? It's containment. But all we have to decide is what to do in the time we are given. Again, this is me, my mom, and my grandmother, now in California, I will say that for the United States citizens, I'm the anchor baby. My parents were allowed to come to the United States after they repealed the Asian Exclusion Act. They came as students. I was born to them as a student. They weren't citizens yet. They were still citizens of Taiwan. They came, I was born, had birthright citizenship, which they're trying to repeal. Then my parents applied for H-1B visas, and then they applied for citizenship. And then they brought my grandmother and my grandfather over, who retrained and worked as doctors in the United States of America. And I think we are what makes America great, and I think we are what makes Taiwan great, because my parents have now reapplied and gotten that Taiwan citizenship back. They tell me I'm eligible for Taiwan citizenship, which is a comfort sometimes. But no, regardless, we are what makes, I think, the world great, this cross-pollination of medical and non-medical education. So what is the truth? When I stop worrying and doom scrolling, is that people really do still trust their own doctors. This is why medicine is wonderful. No matter what politics your patients have, and I have plenty of patients from all over the place. This guy's a libertarian, which he didn't trust vaccines before all this current business. He was my different patient with pancreatic cancer with a Whipple operation. Vaccines were just out when he had his Whipple, to 2021. He would not get vaccinated. Pre-op, intra-op, post-op, and people kind of got sick of him. And he's an old vet. He didn't want vaccines. But I kept joking with him. I said, Doc, every time I come in here, you're going to bug me. I'm like, yep, if you were a smoker, I'd bug you about smoking. You're not a smoker, so I'm going to bug you about COVID vaccination. And so about 6 months into it, he said, you know what, Doc, I'm thinking I might get COVID vaccinated. And he said, you're the only one I can talk to, because everybody else lectures me. And I said, well, okay, well, why? And he said, well, my grandson wants to go to this concert. And then, gosh darn, people won't let me go to the whatever if I don't get vaccinated. He's like, and they told me I could get a fake card. My friends told me I get a fake card, but I don't really like to lie. And I said, you know what? And I called the MA and was like, someone will take you right now, and you can discuss it over there. And he got the shot before he even knew it. And he did fine, of course, and he took his grandson to the concert too. And you know, we didn't have to agree on everything, but he trusted me because he knew that we disagreed on many things. But he trusted me because he said, you've always been straight. And so I do think, despite this information, if people have a connection with their own doctor, or maybe an empathic AI, but they do believe beyond what they read on Facebook or TikTok. So I was going to bring it up here; it's in my bag, but I will just tell you one final anecdote as a surgeon, and I do think the best tool we have to recruit people into medicine and for medical education is our humanity, beyond all of our tools. There are times that people ask me, how can you be a cancer doctor, especially for pancreatic cancer patients, because everybody dies, and this, A, that's not true anymore, but B, I think if we weren't there, the patients would still be suffering. We just wouldn't be there for them. So if I choose not to experience that pain, I'm only protecting myself. I'm not helping the patient in any way, shape, or form. That suffering is still there. So this is my patient, Leo. He came to my clinic, and I had resected him years before, and then he recurred. And he had got every chemo, and he was out of options, and he'd done all kinds of things. And he came to my clinic, and he was in a wheelchair, and he was being pushed by his nephew. And you know, at this point, there's nothing to talk about, and it's all been said. He doesn't need to know about prognosis. He knows, but he's come to see me anyway, because we like each other. And I said, Leo, what do you have planned? Now, I didn't know whether he was going to say he was going to watch TV or whatnot, and he said, I'm thinking I would go to Foxwoods, and his Foxwoods is a casino, and his nephew was like, Uncle Leo, and I was like, can you go? He said, yeah. He said, this guy's giving me a hard time, but he'll drive me. I don't like to gamble. I said, you know what, Leo, I think you should go if you can, if he'll drive you. And he said, you think? He's like, it's not bad for me? I said, yeah. He's like, there's cigarette smoke. I'm like, Leo, come on. And so I actually had $20 in my pocket that I keep for, lunches and things. So I said, Leo, will you play some slots for me? And I asked him what he did. He plays 25-cent slots. And so he said, no, I can't take your money. I said, no, I'm not giving you money. This is an investment. I said, you're going to win. And so I came back. I had gone somewhere, and I came back from a trip a month later, and he wrote me this letter that said, basically, I won $75. and so since it was your $20, I figured I would give you more than half. So he said, I gave you $40. I thought that was fair. so he left this letter, and he sent it to my clinic, and then it didn't come to me in clinic, and it ended up in my office. So I called him the day I got the letter, and I got his nephew, and he said he passed away the week after he went to Foxwoods. But he when he won, he was so happy, And so I think, I didn't cure his cancer. I gave him some years, we gave him years. But the fact that I was able to be there for that patient, that's a privilege. The fact that that was the best gift that he could have ever given me. And I have this, it's in my bag right here. So anyway, and this over here, that's that guy, the middle guy, the panel, with, and that was right before COVID, so 2020, January 2020. But that's the guy with the replaced right hepatic artery and the replaced portal vein patch. That's Sean, who gives permission and wants you all to see this. But so Sean now, he said, Doc, I need to worry about getting old. I thought I was going to die. Now I've got arthritis in my knee. So he's more than 20 years out. And he walked his daughter down the aisle right before this. And not everyone's like that. But to be able to participate in the Leos and in the Seans, and Liz is his wife, of the world, what a privilege. So I would say it's to inspire for medical education and the future of medicine. I think it's bright. We have people like Janie Wong who want to go into medicine, right? I hope what we've seen here today and yesterday, doesn't discourage her, but inspires her. My son, who's a freshman in college and has had his own issues, but he still says he wants to go into medicine. I'm not going to tell him that Jamie has an amazing GPA. He's never going to get into med school, but it's a combination of the best technology, the highest technology, the human touch, and careful decision making, and shutting out the noise as best we can. this is when I was, and I will, I'll answer questions later. Somebody wanted me to talk a little bit about being a woman in the special complex that it approaches and surgery and stuff. But enough's been said about that, and I've written about it. But I want to say that there are so many positives to being a woman or a parent, if you want to be a parent in medicine and in surgery, that there are too many to count. And I will say that when my kid was about 7, the day of the first one, that I went in a rush, late to parent-teacher day, and all the moms, he was in private school at the time, it was very privileged, and none of the moms were including me and one other, but the boys had done out their lockers. When I grow up, I want to be. And most of them had said, when I grow up, I want to be a Red Sox player or a Bruins player. One said, I want to be a billionaire. And my son wrote, when I grow up, I want to be a cancer surgeon, which he misspelled, because I like to help people. And he has what looks like a terrified person, but it's supposed to be a patient on a gurney. And then he thinks it's a scalpel. It looks like our vegetable knife at home. It's serrated. But, you know, like it was one of those things. Your kid, my kid at least, they may complain, but they realize that when you're in the hospital, you're doing something important. That you actually, what you do has value. And I think that if we realize that we have value and what we do is important, I think we can convey that to the ones that come behind us, that we on balance love what we do, and that we try to contain the parts that we don't love. So these are some future surgeons that are trainee surgical residents that gave me a big present in January when I stepped down from the chair role. And then, again, I figured out a better way to say this in Western language. This is what I said before, like, 计划没有变化快. Then what I said was just like, so I'd heard before about God laughing at people that make plans, but I didn't realize, I think the original is Yiddish, and so it's Mantracht, if I say this wrong, Mantracht, Ngotlacht. So it's, I will translate it in non-sexist language, people plan, God laughs. But that doesn't mean we shouldn't plan, right? We just need to try to plan for what might be, and give ourselves some grace. I will see if I can play the final one. So this is us, and you're here, I guess it's Shifen, where we have lanterns that go up to the sky here in Taiwan, and I can see if I can play this final thing with my family and I, trying to get a lantern up. Will it play? Here's a video with that.
Everybody hold attention.
First
And
here,
guys in case
I have a whole
they
other
are
hand.
something to get
We painted things that were Chinese and English. Happy New Year 2025 and health. So despite imperfections and holes and sort of chaos, we send a lantern up to the sky. So I'm sending a lantern up to the sky for the future of medicine, and I think with people like this, everybody and our trainees in the audience, I think the future of medicine and science is bright. Thank you.
Thank you, Dr. Tseng, for such an inspiring presentation. We have a few minutes for questions.
Okay, thanks for your expert stories, and congratulations, all your patients trust you and become your face. As a neurosurgeon, I recognize, as you mentioned, we are repeating the age of innovation, information, and increasing disconnection. Well, AI and high technology is an inevitable trends, like offering undeniable benefit in medicine and medical education. However, do you think delay brings some unintended change or risk that we must address?
Yeah, are you asking what trends that are going to need to be addressed, or is that a comment?
I think the relationship between patient and doctor become weak and doctors depending increasing on AI to make diagnosis and treatment. So if the AI fail or there's something wrong in using AI, I think that's the result.
Yeah, I think we have to figure that out very carefully, and I think some of the speakers have had different views on this. I really like this idea that has come across all the speakers that I learned a lot from, that we need humans plus AI. So we can't let humans absolve themselves of responsibility, because in the end, how are you going to sue an AI? And I don't mean to be, but we are responsible. My husband's a cardiologist, and the old, very simple days of the ECG machine, giving an auto read, you know, when the fellows do it, it's very easy for them just to sign off, click, 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 click on the auto read, which, as we know, is usually wrong. Those ones. But now, since the AI writes so much, we need to be able to realize, how do we overread the AI? What are the most likely errors, and where do we really have to make sure? And then I would argue, and I'm sure the experts know this, and I would defer to the others, how do we have a built-in, how sure am I, for the AI when it says something? Because the problem with I feel like the AI represents like the worst of surgeons. Because surgeons, this classic surgeon, which I think I am not, is sometimes wrong, never in doubt. That you never think you're wrong. And with the AI, it's so confident when it's wrong, when I've seen it wrong, the hallucinations that we talk about. So how can we in medicine build in a kind of a warning? How is it going to know? There's got to be degrees of confidence in its prediction, and then having to train our trainees and us to work with AI to overrid it or to overrule it.
I looked at the schedule. Actually, we have a few more minutes for questions and answers. If people have more questions for Dr. Tseng or any of our panelists before Dr. Paul makes a concluding remark.
There was a student yesterday, I'll keep talking to someone raises their hand. There was a student yesterday, it was a female student from a different medical school with two male colleagues from Keynote, so I'm not sure she's here. But she asked me to comment. I don't, you're going to circulate the recording or not? This? No.
Usually we were planning to circulate.
Oh, perfect. Yeah, so she asked me to comment on this, I guess, but of the women question and women in medicine, I think, in general, not just surgery. And so I've been asked to talk about that a lot. I will say I have a lot of hope, because A, it's inevitable. You know, 60% of medical students, I think, or almost 60% of medical students in the United States are female. And honestly, the surgery residents in the United States are, in academic programs, are often more than 50% female too, in general surgery. And it's still, orthopedics and stuff is still a little bit less, and there are others that are actually more. But it's a sheer numbers. So right now it's at the bottom, it's more, and there's very few full professors and chairs and things like that are female, but it will get there. And there is some attrition in both ways along the way, because women, although they stay in medicine, they may not, if there's a two-body problem, or if there's a child rearing to do, they may not elect to be the highest revenue generator, and there are barriers that hold people back as well. Perceived leadership, that's true of Asians in the United States too, that we were not perceived as leaders necessarily in Silicon Valley. You know, many Asian engineers are passed over for leadership and same in medicine then as well. But that being said, I think that will change. And actually what gives me hope is that men also are interested in work-home balance now too. My male trainees, ones that are married to women, even ones that are married to women that have traditionally secondary careers, are not interested. The women are not interested in being the stay-at-home wife of the surgeon, male surgeon that works all the time. Male-female relationships have changed, even in what are perceived as traditional relationships. So I think both the women and the men are voting with their feet that they want a more humanistic work-home integration for physicians. There's something for us all to figure out that I think makes it much less of a women problem. important, thank you for the question, that we have these exchanges, because Dr. Huang alluded to this yesterday, that, and we just learned more about it at lunch, is that the time pressures that Taiwanese surgeons are under to see 40, 60 patients in a session, that is almost unheard of. I mean, you might see a hand clinic with that many patients, but, and we, I think, didn't realize how hard the surgeons were working, the doctors are working here to do that, and how it's sort of impossible to have that. I think your clerkship, you're probably seeing the best case scenario. I think the United States too, and maybe it's inpatient medicine too, which is a little bit different. A busy primary care doctor in the United States will still see 30 or 40 patients sometimes in a session, but a busy primary care doctor often will then have assistants and stuff like that to help, although not necessarily paid that much in clinic. So you're probably seeing inpatient rounds where they actually have some time to talk about tests and things like that. But still, I didn't realize the pressure, so it shows us we have stuff to learn from you and you have stuff to learn from us. I don't have a solution, because if Dr. Huang was telling us that they have to do, otherwise they're not going to get paid, they're not going to be able to make a decent salary unless you're at this university or this medical center, the enlightened one, that you're not able to actually make a salary to support your family if you don't see that many patients. So I think coming somewhere in between has got to figure it out. It's got to. The U.S. is moving in that direction. We've seen more and more and more patients, or at least trying to figure it out, or maybe seeing fewer of the patients that don't have good insurance, and that's not good either. That's decreasing health equity in the United States. So I'm sorry that I don't have a good solution, but I don't idolize what we see in the United States, because you're probably seeing a better case scenario, and we won't idolize your universal health insurance that you have here.
Any other questions? Yes, please.
Hello, this is Mike. Hello, I'm also a student from National Yangming Japan University. You talk about a lot of your positive experiences. Do you have any negative experience?
In my life, ever?
Yes.
Of course, but there's a reason I'm a surgeon. Surgeons are optimists. I remember the one day. We remember the one day where we got off on time. We had a nice breakfast, and then we got to work. The commute was okay. There were 3 cases. The OR turnaround time was not bad at all, and there were no complications. The families that were all in the waiting room when I looked for them. I actually did my dictations, and then I drove home and actually saw my spouse for dinner. We remember that one day, and that's what we hold as our platonic ideal. No, of course I've had, of course we all have negative experiences. We all have, and I guess that's important too, because I'm realizing that I'm as older and older, and I have a longer introduction, that people look at you and they think that somehow you had a perfect path. And so I'm here to tell you that I've made plenty of mistakes, and I've had bad things happen to me, and the things I wish I had done differently. But I don't have all the time in the world to tell you about that, but just know that there are negative things.
I just wanted to say for this, for the students who are asking about good days and bad days and how to have more time with patients, I think one piece of advice I got was to be involved in leadership, to have more physicians at the tables making the decisions. And you have such examples here in Taiwan of how physicians are involved in leadership of the country. And I think it's so important for us to work with each other to find the solution so that you can have enough time to see the patients, to connect with your patients, to see enough patients so that patients get access to care, and that there's those perspectives. And I think in the United States, we don't have enough physicians sometimes at the tables that are making the decisions about how healthcare is delivered. And I think that is actually very wonderful that I've just seen here in Taiwan of just how much physician input there is in those decisions.
And I would say also, just because people tell you have to do things a certain way, doesn't mean they actually have to do it that way forever, or that that's the choice that you need to make. I will tell you a mistake that I made was at one point a woman who was my age but was behind me in residency training because she actually had a life and was a consultant and things before she went to medical school. But she came to me when I was a medium faculty member, she was a young faculty member, and she told me that she had her first kid or something, and she said that she was going to go to 80% time. And she said that she was making more RVUs, so she was doing more billable units, so seeing more patients and doing more surgery than anybody else in her division, but because she was at one of the clinics. So she was at a hospital that's academic, but was very much saying she had to do this many, they had to have this many clinical sessions. She wanted to have one day where she could drop her daughter off at school and pick her up. And she would come in during the day, that day, not be paid for it, and finish her documentation and do some academic stuff. And I told her name was Sharon, I told her, Sharon, that is crazy. You do more, you're billing more than anybody else in your division. They're all guys, men. And you're gonna take a 20% pay cut and go 20%, get 20% less respect, because I know what happens when people go part-time in the United States. And she said, I need to do this. I need to do it for me, I need to do it for my daughter, I need to do it for my marriage, but I also need to do it for me. And I told her it was the wrong thing to do. I went on record as saying it was the wrong thing to do for her, and telling me this. And I told her I made it work, and I was a pancreas surgeon, and I took my daughter in on Fridays because it was I did research in the morning and I did clinic in the afternoon, and she was right and I was wrong. Not that it was right that she had to do it, but because of where she worked and her husband's job and what she could do, it wasn't correct, it wasn't fair, but she did it, and it was the right thing for her to do. For her, so I was wrong, and she was right, because I was sticking to my principles, and she was figuring out what was right for her, and so in that sense, that's a mistake that I've made, and so, but you can think outside the box. Even when someone she looked up to was telling her it was the wrong thing to do, she stuck to her guns and did this 80% thing for some 4 years, and then went back to being 100% and becoming division chief and all this kind of stuff, and she was right and I was wrong. So you can do something different. So I don't know what that would look like in Taiwan, but it is maybe, doing some equivalent to that. Saying I'm not going to see those, I'm going to have one day, half a week where I don't see patients. And you can cut my salary by 15% or whatever it is. I don't know how it would look in Taiwan. But if they want people to continue to go into medicine, they will probably have to be responsive eventually to you all making those kinds of suggestions.
I just want the students to know too that we have a session at 4 o'clock where we invited all the deans of medical schools. I've seen actually all the deans here in the last 2 days, and university presidents, medical university presidents, and there will be that session at 4 o'clock with Dr. Hall, Dr. Feinberg, and all our speakers, and tell us about the issues they're facing. I think some of them are structural issues, or some of them are sort of methods questions, and so I think that'll be the time to we'll ask them about your questions as well. Any other questions for Dr. Tseng? Well, we want to thank you very much, Dr. Tseng, for your wonderful